So in the next 10 minutes or so, I'm going to talk about the model impact of delays in elimination scale up on cervical cancer deaths averted for 78 lower middle income countries. So in August 2020, the World Health Assembly committed to a strategy to eliminate cervical cancer by implementing the 90-70-90 targets by 2030. So these targets are 90% of girls fully vaccinated against HPV by age 15, 70% of women screened with a high performance test by age 35 and again at 45, and 90% of women identified with precancer or cervical cancer receiving adequate treatment and care. The Cervical Cancer Elimination Modelling Consortium found that if this strategy is adopted, 62 million women's lives could be saved over the next century. So this here is a graphic which was produced by the Cervical Cancer Elimination Modelling Consortium, which shows cervical cancer mortality rates over the next century under a few different scenarios. So if there's no scale up of any intervention targets shown in the grey region, we see that mortality rates do not change over the century. With vaccination only scale ups, which are shown in the blue, yellow and red regions, we do see some substantial impact in mortality rates, but mostly these happen towards the latter half of the century. The most effective strategy was based on the elimination targets from WHO. So that was 90% scale up of vaccination, 70% screening, 70% of women screened twice a lifetime, and 90% of women with cervical cancer offered adequate treatment and care. And that's shown in the purple region. So this analysis also showed the breakdown of the relative impacts of the different intervention targets. With vaccination, we predict that effects won't be seen until around 30 to 40 years after vaccination is scaled up. Screening impacts can be seen within a few years, but most of the effects are observed after 10 or more years. With cancer treatment scale up, the effects were observed immediately, with the full effects observed within 10 years. So where are we with regards to elimination targets in low and middle income countries? Well, we still have a long way to go. The vaccination coverage in low and middle income countries is substantially lower than in high income countries. And the graphic on the right is taken from the draft elimination strategy showing the percentage of countries in each income category that have introduced HPV vaccination into their immunisation programs. So less than 30% of countries in low and middle income and less than 20% in low income categories have introduced the vaccination into their program. We've previously estimated that less than 10% of women in less developed regions are screened, and many of these women are screened with lower sensitive tests like VIA. Cancer treatment access is also minimal in low and middle income countries, and the Cervical Cancer Elimination Modelling Consortium work estimated that less than 30% of women in low and middle income countries have access to adequate treatment and care for cervical cancers. As we've already seen from various speakers in the last couple of days, COVID has disrupted existing services substantially for a variety of reasons, including staff redistribution to COVID-related services, patient safety concerns with attending clinics, and lockdowns preventing movement and access. With HPV vaccination, there's been substantial delays in terms of vaccine shipments being disrupted because of impacts on the airplane industry. And for school-based delivery systems, these have also been significantly impacted because of school closures. And some low and middle income countries that were planning to implement HPV vaccines into their immunisation programs this year have decided to delay introduction for at least 1 year. Of course, in the background, we're dealing with a global vaccine supply shortage, and this is likely to impact vaccination programs, new implementations of vaccination programs for at least the next few years. Screening programs have been substantially impacted across the globe, and cancer treatment services have been significantly affected with postponed or cancelled surgeries and other key treatments for cancers. And also people have not been presenting with symptoms to the clinics, as we just saw from Freddie and earlier speakers, that there's been a reduced number of delayed presentations with symptoms, which is likely to result in stage shifting over the next few years and a subsequent increase in mortality. So in this talk, I'm going to present model estimates of the additional deaths that would occur due to the impact of a 1-year delay in all the elimination targets. So we model an impact of a 1-year delay in vaccination scale up, a 1-year delay in cervical cancer screening and pre-cancer treatment scale up, and a 1-year delay in cancer treatment scale up. So I've just got a little bit more detail about what we mean by a 1-year delay. So with the cervical cancer elimination modeling consortium work, we did assume that 90%, we did assume that 90, 70, 90 targets would be reached by 2030, but there was also some increase in coverage of all the 3 interventions before 2030. So we assume that 90% coverage with HPV vaccination would be reached from 2020 onwards. For cervical screening, we assume that 45% coverage with cervical screening would be reached by 2023, and that this would increase to 70% by 2030. And for cancer treatment services, we assume there was a background rate of around 30% of women having access to cervical cancer treatment. This would scale up to 45% by 2023 and then reach 90% by 2030. So in this analysis, when I model a 1-year delay, I assume that vaccination scale up would be delayed from 2020 to 2021. Screening and pre-cancer treatment scale up would start in 2024, and cancer treatment scale up services would start in 2024. So everything's shifted by a year. And I just thought I'd explain a little bit more of the technical way that we captured this. So with regards to a delay in HPV vaccination scale up, the way we modeled this was we assumed that a 1-year delay would mean that a birth cohort would miss out on vaccination. So for example, if we have vaccine females aged 9 to 15-year-olds eligible for vaccination in 2020, then those who are 15 would then be 16 in 2021 and no longer eligible. And we count the number of additional deaths that this cohort would experience over their lifetime if they were not vaccinated. Similarly, for cervical screening delays, we assume that women who age out of the recommended age interval for cervical screening in 2024 would no longer be eligible, and we count the number of additional deaths that occur over their lifetime. For cancer treatment delays in scale up, we count the number of women who have cervical cancer in 2023. They would have received a survival benefit if cancer treatment services were scaled up, and in the event where cancer treatment services are delayed, they do not receive that survival benefit. That's the model technical details of how we counted these. We also did an exploratory analysis, which is looking at a worse than status quo scenario, where we look at the impacts of COVID on delayed symptomatic presentation for cervical cancer, assuming that women do not present for 1 year, and we also look at a scenario where they do not present for 2 full years. In this case, women might progress to a more advanced stage, and hence there'll be more deaths. To perform this evaluation, we used the Policy One Cervix model platform. This is a dynamic model of sexual behaviour, HPV transmission, cervical screening, and vaccination. This model platform has been used in a variety of settings and for a variety of different research questions, including a key one, which was as part of one of the 3 models that form part of the Cervical Cancer Elimination Modelling Consortium. This slide shows the results of the impacts of a delay in elimination targets of 1 year. So by delaying vaccination scale up by 1 year, we predict a total almost 150,000 additional cervical cancer deaths over the lifetime of that cohort. For screening and pre-cancer treatment, we predict over 130,000 additional cervical cancer deaths with a 1-year delay. And for cervical cancer treatment services, we predict over 47,000 additional cervical cancer deaths. In total, a 1-year delay across all 3 intervention targets is predicted to result in over 300,000 additional cervical cancer deaths. For the exploratory analyses, we found that if cancer presentation is delayed by a full year, an additional over 30,000 additional deaths will occur. And if we have a 2-year delay in cervical cancer presentation over the next couple of years, we predict a total of 77,000 additional cervical cancer deaths due to the 2-year delay. So in conclusion, we found that for each year there are delays in scaling up the 3 elimination intervention targets. We would expect an additional over 300,000 additional deaths to occur over the lifetime of the affected cohorts, assuming there's no catch-up for the missed cohorts. This number represents 1/4 of the total global deaths that are predicted to be directly due to COVID-19 for the year 2020 alone. Of these 300,000 additional deaths, we predict most of them will come from HPV vaccination or cervical cancer screening scale-up delays. In addition, we found that if the current status quo worsens and women delay presentation with symptoms, over 30,000 additional deaths could occur with a 1-year delay, and over 70,000 deaths would occur with over a 2-year delay. So what can be done? Well, as we've heard from a few speakers, vaccination programs could offer catch-up to older females to ensure that all girls that would have been vaccinated in 2020 will receive their vaccination. We anticipate that catch-up programs could mitigate most of the damage. Similarly, with cervical cancer screening programs, we could offer screening to women who have aged out of the recommended interval as a catch-up, and we would expect that most of the damage that we predict would be offset by this catch-up. However, with cancer treatment services, a lot of the survival benefit from scaling up these services really comes from treating immediately the women that were diagnosed, curative surgeries, radiotherapies, and chemotherapies. And so later action for these women is unlikely to really mitigate a lot of this damage. So in conclusion, extending the recommended ages for screening and vaccination could mitigate the damage from the delays from these 2 interventions. However, we need to ensure that women with symptoms can be safely investigated and prioritize access to cancer treatment services to prevent the thousands of additional deaths. So thank you for that. And I believe I'm now handing over to Emily Berger as our next speaker.